Good morning all. So as we have started our HII surveillance in the institute, we thought it will be the right time to go in depth of the surveillance aspects and discuss these aspects, whether ICNs also will benefit of this topic. So as a whole, HII surveillance itself is a quite complex topic which has multiple nuances to be known to the depth. So I thought I will just discuss the most complex one, the first, surgical site infection surveillance. So I will be targeting or going to the talk only about the surveillance aspects, not about the surgical site infections. So as a whole, healthcare associated infection. We are all aware of this terminology, HAI terminology right now. It is healthcare associated, not hospital acquired or hospital associated. It is healthcare associated infection. Any infection developing in the patient after 2 days of hospitalization. That is a very broad definition of a healthcare associated infection. It is just any infection, not only these 4. But for a surveillance purpose, to have a proper goal and to have a proper monitoring of infection prevention control activities and things in a hospital, we are just taking the 4 most important ones which are highly contributing to the mortality and morbidity of patients in the hospital. So these 4 are specifically considered as a HAI infections. So surveillance is basically done for all these 4 infections. Out of these 4, if you notice, the first 3 ones are all device associated infections because there is a presence of or association of an indwelling device in all the 3 cases in first 3 ones. The surgical site infection is the different one. The surveillance is also quite different compared to the initial 3 ones. So I will be targeting only about the surgical site infection surveillance today. So before going into the surveillance as such, like what is surveillance and what is the need to do that surveillance? So surveillance comprises of these 5 key stages. From the data collection. Collecting a plenty of data does not mean anything. So it has to be approved. Which data has to be validated or which has to be analyzed. That also has to be seen. So validation is also quite an important component. Then it has to be analyzed, then interpreted. Out of all these, it should be disseminated properly to the necessary clinicians or the hospital administration. Then only the action can be taken of all these surveillance activities. So all these 5 are quite important in any surveillance aspects. So ultimate aim is to reduce the HAIs, healthcare associated infections reduction. Establish a baseline HAI rate. So in any institution, before just going and implementing the infection prevention activities, there should be a goal or a target against which we are trained and implementing or improving our infection prevention activities. So that goal is basically your HAI rate. So we are going to get that baseline data in any institute, and then by towards reducing that HAI rate, our whole infection prevention activities will be targeted. Comparison between different facilities or between a different location in a hospital, like surgical ICU or a medical ICU. So is there any specific increase in cases in a particular location that we can compare if we have a proper HAI rates? Or from a different institute. In Andhra Pradesh state itself, we have multiple hospitals, government institution, private institution. We can have a comparative analysis between the institutions if we have a proper HAI rate in different institutes. Convince the clinicians to change and adopt infection prevention control activities or practices. So this is always an important thing. So it's not always easy to change the practice which is already happening as a routine protocol in any institution or in any case. So to have a consistent change, to adapt new things in the hospital, we need to have a solid data or a solid proof. That proof comes with this HAI rate. Identify, monitor and control of an outbreak. So even if there is an unusual increase in cases, that we will be able to detect at the early stage if we are doing this surveillance on a routine basis. Evaluate the success and sustainability of infection prevention control interventions. Intervention you have introduced now, like hand gauge intervention is introduced. Is it properly reducing, or is it giving the success of reducing the HAI rates, or is it sustainable? So all these things can be assessed by doing this surveillance itself. So this is the whole purpose of surveillance. And the types of surveillance, there are plenty of methods again for doing surveillance. So active or passive surveillance. So passive surveillance is basically the clinician is reporting the HICC committee. If there is no HICC team as such, or if there is no infection control team with an infection control nurses, the clinicians at the end of the month they will report like this many cases I have got in my place, in my ward, to the HICC committee. But even there, lot of cases we are bound to miss. So there is a need for active surveillance to take place to look for these HAI rates. This active surveillance can be done by these ICNs, infection control nurses, and that is the most accurate and recommended method. They will actively look for HAI presence in the hospital. Sentinel event based or population based surveillance. So event based, like a salmonella outbreak has happened or salmonella positivity has happened in the hospital. Only those patients will be listed in the surveillance. So only those patients will be looked for. Whereas in HAI, in an ICU, if you take all the catheter days will be calculated for all the patients who are having catheter in the ICU in the particular day. It's not only the persons who are having the infection. So all the population is targeted or monitored. Out of them, we are going to look for the specific formation of or initiation of the HAI infection. So population-based survey is widely practiced. Outcome and process surveillance. These two small terms. Outcome, basically, the thing has happened, like HAI, catheter associated UTI has happened. It's already finished. So outcome has already happened. So if you are monitoring or surveillance, doing surveillance for that all the HAIs, it is all outcome-based surveillance. So it has already happened. Whereas process, it is like hand hygiene. Hand hygiene is a process. A bundled care method is a process. Or PPE auditing, it is all a process. So to check whether the process is proper or not, surveillance can be done. So all these are process surveillance, and the proper HAI rate as calculation is an outcomes-based surveillance. Where do we do what? If our institution is so big with more than 200 beds, in that case, actually, it is needed to have both process as well as outcome-based surveillance. Just by looking at the outcome, we may not we may not have a proper knowledge about the implementation of infection prevention activities also. So to have that proper implementation activities or not, we have to have the process surveillance also. So we need to have a both outcome as well as process surveillance if the institution is big. Suppose in a smaller institution where the bed size is less than 200 and only fewer adverse outcomes are expected, if HAI rates are already very less, in those cases we need not go for full outcome based assessment, we can just do the process assessment. That means basically your hand hygiene will be kept proper, your biomedical waste management segregation will be proper, PPE auditing will be kept in control or proper. So those process we streamline instead of looking at the outcome rates. So that's what is being told. More to this, like population, patient population coverage. So sentinel event and population based, I told population based is better. In population, are you going to look at all the population, all the patients in the hospital? Ideally, that is good, but the feasibility and maintaining the data, collecting the data and all those things will be quite complex for all patient surveillance. So it is always targeted surveillance. So especially in case of high risk areas or in ICU. So these HAI rates will be looked at those locations only. So by targeted surveillance, targeted patient surveillance. Surveillance team. So who will do that surveillance as such? So it can be also by multiple methods. Like in the ward, whenever the patient is getting an infection, from the ward they can collect all the data and they can analyze the data and they can also present. That is one thing. Then from laboratory side, so in laboratory we are getting the samples, we are reporting the samples as culture positive. So we can also do the collection of the data, we can collect the whole data in this month, this many culture positives have come from this ICU. That way also we can do. But we will be missing lot of clinical data in this. The NHS and CDSC has given a proper fixed objectified guidelines for calculation of these HAI rates. So if you just do clinical analysis, you will miss the laboratory data, and if you do the laboratory analysis, you will miss the clinical data. You will not be able to categorize or localize these infections in specific groups if you do either of this. So it is always a laboratory based ward liaison. That is the most recommended as well as a gold standard method of surveillance. So the ICN, infection control nurses, should be specifically appointed in the hospital, and they should be in liaison with the ward as well as the laboratory. So whenever a positive case comes in the laboratory, they should be able to pick up those cases, and whenever an infection is suspected in a clinical patient, that patients also they have to be able to pick, and they should correlate these two findings to report the HAI infection. So this is the gold standard method to be done for a surveillance. Prevalence or an incidence surveillance. So at a particular point we can get the prevalence, like how much HAI is there in a single day, but that will not solve a very purpose. We need to have a proper data. So always it's better to have a prospective incidence surveillance. Like it should be a prospective, like over a period of month. In this next 1 month, how many new cases have come? So that will give a productive data for a surveillance. So these are the varieties of surveillance. So whatever these 4 surveillance which we are talking about, it will be a mix of many of this. So especially for SSI surveillance, it's going to be active, patient-based, prospective. The extra thing is it will be concurrent as well as post-discharge surveillance. So all the other infections usually it will be while they are admitted in the hospital. The device-associated infections, the patients will be admitted in the hospital and we will be monitoring the rates. Whereas for a surgical site infection, even after the discharge, we need to follow up those patients to record those proper data. So that is extra here for surveillance. So in this era of advanced infection control practices, so we have improved proper modular operating room ventilation, advanced sterilization methods, multiple barrier techniques, even surgical techniques have improved, and proper antimicrobial prophylaxis. All these have been implemented more or less in most of the hospitals. Even then, surgical site infection is very important because it is the substantial cause of morbidity, mortality, and prolonged hospitalization and economic impacts. Out of all the 4, this is having the major contribution as such in the economy as well as hospitalization and morbidity and mortality. So 20% of all HAI is your SSI, and just the mere presence of SSI increases the mortality rate by 2 to 11% in a patient. Both patients operated on the same time, same type of a procedure. If the one person gets SSI, the mortality rate increases by 2 to 11 times. That is quite high. And 75% of SSI associated deaths. So the persons who are dying, those who are having SSI and those who are dying, 75% of time that is associated with the SSI. That is due to that infection they are dying. So that is also quite alarming because of the mortality rate. And it is the most costly HAI because they need to have a long-term admission, long-term follow-up and everything. So the most costly HAI is your SSI. So global estimates roughly says 0.5% to 15% is the chance of SSI. Studies in India have documented around 20 to 40%. That is roughly around 1/3 of the patient. 1/3 of surgical patients are getting SSI in India right now, as per the documented data. So about the surveillance as such, so how do we get the data? SSI, it's quite complex. We need to have varieties of data over the period of time. So what are types of data and from where you will get the data? So medical records and charts. So whatever patient charts are there in front of the patient, or the medical record from the file, including the operation notes during the surgery, while opening or during the surgery, like what all findings they have found during the surgery. Even that data is essential for the SSI criteria. So you need to look at the operation notes also and get the data. Laboratory as well as imaging and other diagnostic test reports. So lab reports are also quite important. So surgeon's notes, as I already mentioned. OT and ward rounds. So the ICNs have to go to the OT as well as ward and find out the onset of infection, like any symptoms, clinical signs and symptoms, all those things they have to analyze and find out. So patient is operated today. In this era, like patients are admitted only for 1 or 2 days post surgery. They are usually discharged after very few days. So, but how are you going to follow up? Usually SSI surveillance, you need to have a follow up of 30 days minimum to a maximum of 90 days. So how are we going to follow up? So it's by either a mail or a telephonic conversation. So there are lots of fallacies also, but there is no other go. So patient has to be regularly contacted and asked for the specific signs and symptoms of surgical site infection by mail or telephone. So all these varieties of data are needed to have an analysis about an SSI. So NHS operative procedure codes. So what you consider as a surgery? A person can have a varieties of opinions. So somebody can call a very small thing as a surgery. Somebody may not say that it is a surgery or a procedure. So what you have to target when you are calculating an SSI. So NHSN has given out a clear-cut criteria or clear-cut procedure codes. So only if these codes or these procedures are performed, then only we will consider them as, we generally look for SSI in those procedures. Otherwise, we will not even consider them as a procedure or a surgery. The clear exception is circumcision. Circumcision happens in the OT inside the hospital, but that is excluded from the operative procedure code. So for us, SSI in a circumcision patient, not possible. Okay, so that's a thing we have to follow. This is a whole list of
What is NHSN?
CDC का National Health Surveillance Network. So this whole codes and data are there in the NHSN website, readily available. Apart from these codes, apart from these surgeries, at least one incision should be made. When you call it as a surgery, at least one incision should be made during the surgery. If already an existing incision is there, if the surgeon is re-entering through that particular incision site, then also it is included as a surgical procedure, and it should take place in an operating room. So operating room can be a proper operating room, even the interventional radiological procedure room, that is considered as an operating room, or a cardiac catheterization room, even that is considered as an operating room. So these are the criteria when you will suspect or think of SSI. It should fit in any of the procedure codes. One incision should be made, or if already incision is there, re-entry should have been there from the incision site, takes place in an operating room. These are the definitions commonly used for other HAIs, like device associated infections. We commonly use this infection window period, present on admission, and repeat infection time frame terminologies. But all these terminologies are totally not relevant in case of SSI. Instead of present on admission, this terminology is PATOS, present at the time of surgery. So that terminology is adopted instead of presence of admission. So evidence of an infection at the start or during the surgical procedure. So this will be usually documented in the operational notes, so surgical notes by a clinician or surgeon. So what all things we can take from the surgical notes. If there is a mention about an abscess in the surgical note, that can be taken. If the presence of purulence or pus, that can be taken. Infected and ruptured appendix, that can be taken as an infection. Fecal and peritonitis, or the word infection is mentioned in the operative notes. If either of this is mentioned in the operation notes, then we can take those cases as PATOS, present at the time of surgery. Again, the thing is here, we have to localize the site. At what site they have mentioned all these things, and what site the SSI has happened. Abscess, intra-abdominal abscess in the deep space, that is documented in the surgical notes. But the surgical site infection happened at the superficial incisional site, in the skin level. Then PATOS will be negative or no. PATOS should be written as no. Intra-abdominal infection abscess, and infection as such happened in the superficial layer, in the skin. So in that case, it will not be entered as PATOS, present at the time of surgery. It should be at the same level. So SSI also we are getting in the skin level, and purulence or pus or abscess is also documented at the skin level. In that case, you will not enter it as PATOS present. PATOS yes. All these similar things which are not entered as PATOS. Use of the ending itis in the operation note. Peritonitis, appendicitis. So that is a common terminology used by everyone. Just by the presence of itis, we should not take it as an infection. Itis is just inflammation. Need not be an infection as such. So just by seeing at the presence of itis, you should not document it as PATOS present. That is one thing which we need to look at. Positive culture, pathological or imaging report of infection. In the operation notes, surgeon did not see the infection, did not document it in the notes. But you are having an evidence during the surgical, they removed some organ or something, or aspirated something and sent, and there you are getting a positive culture, either by pathological report or microbiological report or an imaging report, documented infection. even then you will not consider that as a POTOS. POTOS is basically the surgeon's notes, visibly what they have seen and what they have documented during the surgery. Only that is considered to be POTOS, irrespective of the presence of infection. These are all the fine nuances we need to be clear with. Colon perforation. Colon perforation obviously means the organisms coming out into the abdomen. That does not mean POTOS, because there is no infection. There is contamination, but infection has not started at that time of surgery. So just colon perforation, necrosis or gangrene or fecal spillage or nicked bowel during procedure, all these are not considered to be POTOS. That means infection is not there at the time. Contamination is there, but infection is not yet come. Similarly, wound class, like dirty wound or infected wound, that is different. So contaminated wound, you will not give it as POTOS. Fresh trauma resulting in a contaminated case. As I already told you, contamination is there, but infection is not started at the point of time, so it will not be included in POTOS. Excluded organisms. So for HAI surveillance, it should be from a hospital or a healthcare institutional onset of organisms. Like these are the proper documented community associated organisms. So for all these organism presence in the SSI, you will not document them as SSI. And organisms associated with latent infection. So even all these infections are not considered to be a surgical site infection as such. So date of event also is quite important here. The mere terminology HAI means after 2 days of hospitalization. But here the hospitalization does not matter. The date of event solely depends on the date of surgery and the other criteria. It does not depend on the date of admission into the hospital. So the surveillance period starts from the date of surgery. From the date of surgery, we start surveillance of the patient for 30 days or 90 days, depends on the type of surgery. When the first element used to meet the SSI infection criteria, so there is a specific criteria which I will talk about in the further slides. When the first element used to meet the SSI criteria, that date will be taken as the date of event, and it should be the occurs for the first time during the SSI surveillance period. 30 days period, after 5 days we are documenting an infection, like SSI criteria is fulfilling. After 14 days, again one more is coming. So the date of event will be the first one. So the first time whenever SSI is documented, that will be the date of event. Deeper lesion is always considered first. So infection can happen at multiple levels. So it can be in the mucosal or muscle or facial level or in the skin level. If both the levels infections are there, we should take the deeper level infection as the SSI. That should be documented as the SSI. It should be a deeper level SSI. Roughly, usually the infection occurs within a 7 to 10 day time frame with no more than 2 to 3 days between elements. There is another possibility, like after the surgery, second day the patient is having some discharge, and after that a long gap, so only discharge is there, nothing else, other criteria are not fulfilled. After a long gap of 10 days or 14 days, again he is having redness or swelling and other things. So both the things points towards infection, but the time duration between these elements are also quite far. So to have an infection at that site, the multiple events, the time duration between the multiple events also should be shorter. This is not a fixed timeline given by a CDC. This is a rough guideline, that's all. Usually they are saying within a 7 to 10 day time frame, all the SSI infection criteria will get fulfilled if there is a proper SSI infection. So surveillance period, as I already told you, it's either 30 days or 90 days based on the procedure, which I will talk in the next slide. Secondary bloodstream infection attribution period. So as the surgical site infection as the source, it leads to bloodstream infection, that is secondary bloodstream infection. So from which period you will give it as secondary bloodstream infection? So from the date of event, 3 days prior, 13 days later. So as per multiple studies, they have finalized these dates. It is different for this as well as the device associated infections. The secondary bloodstream infection attribution period is different in case of device associated infections. Only for SSI it is 17 days. 3 days prior to the event, 13 days after the event. So in this duration, if the patient is having a bloodstream infection with a similar matching organism from the surgical site infection, then that means it will be attributed to the SSI. So it's going to be a little more complex and factual. Denominator data. So basically in any HAI infection, the denominator is going to be the all population, kind of the total catheter days or total ventilator days or total number of surgeries happened. So even here in SSI, the denominator is total number of surgeries happened in that particular duration. But in the denominator, we need to have multiple documentation of data. In the denominator, all the total surgeries we are documenting. For each surgery, we need to categorize them in these particular groups. That means basically in each patient, we have to document all these data. Whether it is a diabetes is there or not, whether it is a general emergency operation or a routine operation, inpatient or outpatient, what type of anesthesia is, duration of surgery, all these things matters. For comparing the surgical site infection data from one hospital to another hospital, it can vary a lot. Like a hospital who is doing surgery specifically on a immunocompromised persons or oncology patients, the surgical site infection rate can be quite different compared to a patient who is operated on a daycare basis. The rate can be totally different. So to have some comparison, the risk has to be stratified. The risk stratification or risk adjustment has to be done before comparing these two HAI rates. That can be done by categorizing the patients in multiple groups. So you will compare the patients, only those HAI rates will be compared. So in our hospital, the total HAI rate will be calculated. Out of that, you will filter the rate by taking only outpatient patients' data. That you will compare with the daycare facility where the outpatient procedures are done or something like that. So that can be comparable. So risk adjustment is done. For that purpose of risk adjustment, you need to have all these variables documented for all the surgical patients which you are entering in a surveillance form. So denominator should have all these values. So wound class, we all know that it is 4 types: clean, contaminated wound, or a dirty or infected wound. So clean is basically an uninfected wound, just a clean cut without hollow viscous entering or going inside. Clean contaminated is also a clean surgery, no documented infection, but hollow viscous is entered in a controlled manner. Contaminated wound, a fresh wound, there is no obvious infection as such, but lots of contamination from a RTA patient, road traffic accident patient, or a colonic surgery. Dry, dirty, or infected wound. Surgical procedure done when the active infection is already present. So these are the wound classes. So obviously the HAI rate will differ based on the types of infections. Already infection is there, heavy contamination is there. The chance of getting the SSI is more in these kind of patients. So if you just take total SSI rate with all these and compare with some institution who is conducting only clean wound SSI surgeries, then the rate cannot be comparable. To make it comparable, we have to categorize all these things and take the data, so that whenever we want to compare, we can localize or risk adjust those data and compare. So we can take our clean wound data from our hospital and compare with the other hospitals' clean wound data. So the depth of documentation of these data are important. Type of wound closure also matters. 2 types of closure, one is primary and non-primary closures. So primary closure is, there should be approximation between the skin. The skin has to be approximated at least in one location. Like in this wound, in a single location, skin is approximated. Here, 2 sides the skin is approximated. Here, almost everywhere they are closed. So all these are considered as primary closure. Non-primary closure is, in some surgeries, anticipating the expansion of the abdominal cavity, like laparotomy and things, they will keep the superficial skin open. Skin layer they will not suture at all. Only that muscle or facial layer they will suture and approximate. Skin layer they can keep it open, or they will just put a suture and then the skin will not get approximated, not even at a single point. That is considered as non-primary closure. Even this matters in case of SSI, so this data also has to be documented. Incision type. So it can be primary as well as secondary. At the same time, in a patient, two simultaneous surgeries can happen. Like a CABG patient, coronary artery bypass graft surgery patient, the primary incision is your recipient site. So from here, the vein will be taken, donor site, and the vein will be inserted in the recipient site. So recipient site is the primary incision. Donor site is considered as a secondary incision. So a superficial surgical site infection, it can be two: superficial primary surgical site infection, superficial secondary surgical site infection. So finally, the classification of SSI. Three types: skin and subcutaneous layer. If there is infection, it is superficial. Muscle layer or a facial layer, it is deep. Organ space, organs or the space cavities are involved. That is considered as organ space SSI. The total duration of surveillance. So again, NHSN has given a proper procedure codes for how many duration we need to follow, which all patients, which all surgeries. On a rough overall basis, breast, cardiac and implant surgeries are usually followed for 90 days surveillance period. All the other surveillance surgical site infections will be followed for 30 days. And all the superficial infections, superficial SSI will be followed only for 30 days. So these are the 90-day surveillance projects. So breast, cardiac surgeries and your implant surgeries will be followed for 90 days. So organ space SSI also, they have given a proper list. So what all will be considered as organ or space SSI. So now specific criteria under each. Superficial incisional SSI. So the green point should be mandatory, and out of all the red ones, if any one is there, that is considered as significant. So totally 1, 2 and any one of this. So totally 3 points should match to get this superficial incisional criteria. So if it is a superficial incisional, it should occur within 30 days of the procedure. Skin and subcutaneous level involvement. Then purulent discharge from the superficial incision. That is one criteria, that can be one of the point. Organisms in culture or non-culture based microbiological testing method. So the organisms are identified by culture or other methods. Site deliberately opened by a surgeon and culture not performed, plus any one of the following: pain or tenderness, swelling, erythema and heat. So it's all quite complex. Site is deliberately opened by the surgeon. So surgeon feels that there is something wrong, so he is opening the site deliberately, but culture he is not sent. Because of these reasons only he might have opened, like pain or tenderness, swelling, erythema or heat. So any one of these points should be there. Site deliberately opened and culture not performed. If the criteria matches in this point, that will be taken as one of the criteria fulfilled. Diagnosis of superficial incisional SSI by surgeon or attending physician. They have their right to diagnose and report the infection as a superficial SSI. So surgeons has the rights to report only this superficial one. They can't report the deep or organ space as SSI on their own. They can report this one on their own. If these two things fulfill and the surgeon is saying it is superficial SSI, it can be documented or it can be reported as superficial incisional SSI. So this is the criteria for superficial. So what all are not? Diagnosis of cellulitis at site. Cellulitis is basically inflammation at the site. Warmth, redness, heat, everything is there, but other criteria are not fulfilled. Then it may not be SSI. Stitch abscess. Stitch abscess need not be infected. Stitch abscess can happen with the reaction to the carpet or other materials. It need not be infected. Stab wound or pin site infection. So stab wound is there. It is not an incisional wound. It is a stab wound and pin site. That after the operation they use a stapler pin to staple it. There is no incision at that place. So all these things will not be considered as a superficial incisional SSI. Whereas laparoscopic site, even there stab is made. that is purposefully made in the operation theatre, that will be considered as a surgical incision and not a stab wound. So laparoscopic site, the port entry, that will be considered as a surgical incision. So as I already told you, circumcision is not listed in the procedure codes, so that is excluded. Burn wound. Burn wound is also the infection whatever is happening in the burn wound. It will not be considered as a surgical site infection, obviously.
Vein site is there no?
We'll discuss it later. Surgical site infection criteria for deep incisional SSI. So if it is a deep infection, the criteria is 30 days or 90 days for those specific procedures. Muscle and facial level involvement should be there. So these two things definitely should be there, and out of these three, either one should be positive. Again, purulent discharge from the deep incision. A deep incision that spontaneously deices or deliberately opened or aspirated and cultures positive or not performed, plus one of the following: fever is there, pain and tenderness. So it's also a multiple combination is given. The wound is opened or aspirated or spontaneously deices. Culture is coming as positive, or if you don't send the culture, that is also fine. If you send the culture and if it comes negative, then this point will not be fulfilled. If you don't send a culture, it's fine. If you send a culture, it comes positive, it's fine. If you send a culture and if it comes negative, then this point cannot be considered. Abscess or other evidence of infection involving the deep incision that is directed on gross histopathological examination or imaging test. So basically other diagnostic methods or even by gross looking, abscess or evidence of infection is located at the deep site. So if one of these criteria along with these two, if it is there, then we will categorize them as deep incisional SSI. Is it going complex? There are further more slides which will be more complex. Organ or space SSI occurs within 30 days or 90 days of procedure as other things, deeper than the fascia or muscle layer that is operated or manipulated. Again, purulent drainage from the drain that is placed into organs or space. So drain is kept from the organ or space, the drain is coming out and it is purulent. So this point will be fulfilled. Organism in culture or non-culture based microbiological testing method for fluid or tissue in the organ space. So organisms are identified from the specimen. Abscess or evidence again by gross histopathological or imaging testing. Abscess or evidence of infection is documented from the organ or space, and at least one criterion for the specific organ or space infection site listed in the NHSN. So this is the extra point for organ or space infection. 1, 2, 3. These three should be mandatory. In this red 3 ones, either one is sufficient, right? So what is this last one? The NHSN again has given criteria for each one of these organ or space infection. Like an example, bone or joint infection. So all the infections they are given. For each infection they are given a criteria. When you call this infection as an osteomyelitis, so one of the criteria has to be fulfilled. So for osteomyelitis they have given 3 criteria. So one should be at least fulfilled by this criteria. Then only we can take this criteria as fulfilled. So 1, 2, 3 plus 1. So 4 criteria should be fulfilled to call an infection as organ or space SSI. So for doing all these things, basically we need to have a deep understanding or knowledge about this NHSN CDC criteria or mapping of procedural codes. So after doing all these things, we will arrive at our SSI rate. So SSI rate is basically the number of surgeries done in the hospital in the particular period. Above we have number of SSI cases which are documented. So the data will be collected for a 30 days period or 90 days period. So after all these data are collected, it has to be validated. So during that validation point only many things will come, like a superficial infection or a deep infection, which one will come first or which you have to take it as an SSI. So multiple things are there for validation of the data. Then it will be analyzed and interpreted and then disseminated. So it will be multiplied by 100, you will get that SSI rate as such. So what are the challenges? As I already discussed briefly, post-discharge surveillance. So patient goes home after a week. Remaining 3 weeks, you need to follow the patient. Patient will come to the hospital, but he will come to the OPD or a procedure room for a dressing change and things. So he will not come to that ward where he was admitted during the surgery or after the surgery. So from that OPD, we should be able to take the data. Whenever the patient comes to the OPD, if during the dressing, if they feel there is an infection or presence of signs and symptoms of infection, that data has to be documented or collected by the AIIMS. So we need to have a proper network at all level to get the data, even from the procedure room or from the OPD and from the patient himself. So patient should be he should have that comprehension of diagnosing and signs and symptom of an infection. Just by telling that pain in that area, pain in these things, we cannot take that as an infection also. He should be educated to tell the proper signs and symptoms of infection while discharge, so that whenever we contact him by telephone or by mail, they will be able to give that appropriate information to document them as an SSI. So even that patient education is also important, and follow-up is also quite important and compulsory for an SSI. So risk factors, as I already told you, present at the time of infection. There is obvious infection present at the time of infection. That means there is very high chance the patient is going to develop SSI. So all these things are specific risk factors for SSI, like similarly the bone class also. So with these things, the rates cannot be compared just like that between another institution or other location. So for that, this has to be adjusted. So those things we'll discuss in further slides. So attributing an SSI to a ward. So again here, after a surgery, initially the patient will be in OT for observation for some time. Then he will be in the ICU for observation for some time. Then he will be allocated in a specific ward. So where the patient is normally housed after a surgery, in that ward we should label the patient as, we should attribute the patient to that particular ward, not the ICU, not the OT. So this attribution is also can be quite complex or quite challenging. Specific organ or space SSI. As I already told you, even for each one of these organ or space SSI, we have to have the criteria followed or checked, and then decide on these SSIs. Procedure code mapping. So all these are software based. In Excel sheet these are available, but it is already quite complex. Even in Western countries, they find it difficult to do the proper category mapping in the Western countries, where the system is totally in place in digital software manner. In our country, there is no procedure code as such for our scenario or our situation. And to utilize these kind of mapping and categories in our setup itself is going to be quite complex. So how are you going to use those data? SSI rate is calculated, but how to use it? Standardized infection ratio. So they call this as SIR, standardized infection ratio. This is the better reliable indicator to compare the HAI rates between institutions or between the locations. Why? Because it is risk adjusted to the location or risk factors in the population. Like only ICU is taken. So this ICU can be comparable to the another ICU. So the risk, only the denominator will be taken by filtering the patients from only ICU. So in that case, we will get only the ICU data that we can compare. So risk factor in population, like diabetic patient. So a specific diabetic patient, all these SSIs in diabetic patients, the data you will take out, that is the risk adjusted data for diabetic patients. That can be compared with the another area, risk adjusted to diabetic patients. So this risk adjustment is basically the standardized infection ratio. Observed HAI by the predicted HAI. So ultimately, in all this risk adjusted area, what is the total predicted HAI which we are expecting in this particular duration? By the total observed HAI in that particular duration. So this will give the SIR ratio. If the predicted HAI is less than 1 in that particular area or in that location, we cannot go for calculation of SIR because the data is so small. So we have to wait for a longer time till we get that predicted HAI to be more than 1 or equal to 1. It should be at least 1 so that we can calculate this SIR ratio in any place. obviously it's going to be more than one in most of the places, especially in India. It's going to be definitely more than one. But the predicted HAI is basically the national data. Do we have our national HAI data? That is a big question. So even if we have a data, is it standardized? Is it according to all these NHS and CDC protocol? There are many institutes who are following this SSI calculation based on the CDC. But even there, the strong adherence to this procedural code data from these NHS and CDC is not guaranteed. So all these data, whatever we are getting from many institutes, they may not be a proper or complete data. So if no national data is there, then 3-year pooled average HAI rate can be used. So you do HAI surveillance for 3 years, you take the 3 years average data in the institution and take that as the predicted HAI, and then you do the calculation for SIR. So in this way we can utilize that SSI data in a comparable manner. So these are my references. National Healthcare Safety Network.
Surveillance.
SSN 2022 guidelines. Thank you.